So welcome. As we celebrate National Minority Health Month, we want to welcome you to our congressional briefing today, Women in Minority Health Innovation Gaps and Opportunities, hosted by the Women's Health Innovation Coalition and G2G Consulting. I'm Amy Sanchez. I'm a Government Affairs Director at G2G, and I will be moderating today's event. In my previous life, I was actually general counsel for the Senate Committee on Small Business and Entrepreneurship, where I actually handled women's business issues. And so this is an issue dear and close to my heart. So I'm really excited for today's discussion. Next slide. So our agenda today is I'm going to attempt to lay the foundation for today's discussion with a few data points and statistics that really kind of demonstrate the hurdles that women and minorities face in their health and ushering solutions, innovation to the marketplace to address those health issues. We're going to have opening remarks by Congresswoman Lois Frankel, and then we're going to welcome our expert panelists, including Sheena Franklin, Valerie Palmieri, Natalie Buford-Young, and Linda Grube. We will then close with our call to action. We will have a Q&A at the end, so definitely make sure to drop your questions into the chat box, and we'll get those answered at the end. All right, and then after, of course, after the presentation, we'll circulate the slides so you have them. Next slide. So the Women's Health Innovation Coalition seeks to identify and raise awareness for how health conditions disproportionately impact women and minorities. As you can see from the slide, there are 8 categories in which women, and particularly women of color, are disproportionately impacted by health conditions. I think, for me as a woman of color and as a new mom, I think 2 of these really stood out for me. That's cardiovascular health. I can see heart disease kills 1 in 5 women, and it's the #1 cause of death for Black women and the #2 cause of death for Hispanic women. To me, that's just startling. And then as a new mom, Black women are 3 to 4 times more likely to experience pregnancy-related death, which is, just looking at these statistics, I think they really demonstrate kind of, just how differently women, particularly women of color, face just everyday health issues. Now with these issues being so dire, you would think that there would be kind of a rush of both public and private sector dollars to kind of support innovative solutions to address these issues. Reader, that would not be the case. Next slide. So you can see that from the statistics here, really, women are, we all need, we need capital in order to bring these solutions to marketplace, but, women, and particularly women of color, are just not getting access to, to those capital dollars, including particularly venture capital. I think one statistic that is not on this slide that I saw recently, from 2016 to 2019, the percentage of women U.S. patent holders has increased from 12.1% to 12.8% in that time. So we know that women are inventing. We know that they're getting patents, but they're not getting the dollars that they need to bring those solutions to health consumers. Next slide. So this is what we're trying to address. I am now extremely honored to introduce Congresswoman Lois Frankel, who represents the Florida's 21st. She's a key appropriator on the Labor, Health, and Human Services Committee. She's been a tireless advocate for women, particularly women's health equity, and she's going to kick off today with a few remarks.
Hi, everybody. Lois Frankel here, member of Congress in South Florida. Welcome to this briefing where we have a very distinguished panel that's going to discuss the barriers and hurdles faced by women and minority health innovators and how we can overcome some of their challenges. I want to thank the Women's Health Innovation Coalition for the work it does to promote understanding and awareness and funding for women and minority health conditions, with the goal of improving patient outcomes and lowering healthcare costs. As you saw from the opening slides, our nation has continuously underfunded and underinvested in women and minority health conditions. Look, progress has been made, especially since women and people of color have joined the Congress. But I will tell you this, as a member of the Labor, Health, and Human Service Appropriations Committee, I have seen firsthand that there's still a lot of work to be done in order to make sure that there is equity in healthcare funding, healthcare research funding also. So one area the panel will discuss today is a call of action. Numerous studies have shown that women and minority health innovators are extremely profitable in improving health outcomes, yet they receive a minimal amount of dollars, awareness, and tailored care that they deserve. So here are some action items. First, let's improve the federal funding for women and the minority health innovators. These innovations are necessary, especially in diseases where women and minorities face different symptoms and health outcomes, such as cardiovascular and gynecological health. I mean, for example, the symptoms of heart disease in women can be much different than men. Number two, let's increase the federal funding streams across the federal agencies like NIH and DOD that will allow entrepreneurs to build upon the current studies. And let's also make sure that CMS and private insurers keep pace with the innovation and provide coverage for FDA-approved diagnostic treatments. Working together, here's what we need to do. We need to ensure that innovators get the funding that they deserve and patients have access to treatment. So no matter what their gender or their race, where they live or their ability to pay, they get the treatment that they need. Thank you again for participating in the briefing. Looking forward to all us working together.
Wonderful. Thank you so much, Congresswoman Frankel, for your powerful words. Huge thanks to our staff for making that happen. What's going to happen now is I'm going to introduce each panelist. I'm going to turn it over to them to give their presentation. Then I'll introduce the next panelist, so on and so forth. We'll have Q&A at the end, so definitely make sure to drop your questions in the chat. And with that, I'm pleased to introduce Sheena Franklin. She's the founder and CEO of Kept Health, a venture-backed AI-driven telemedicine dermatology clinic serving women with chronic skin conditions and illnesses. Sheena?
Thank you, Amy, for the great introduction. And hello to everyone out there. I am Sheena Franklin, the founder and CEO of Kept Health. Before we get started, I want to thank the Coalition and G2G Consulting for inviting me to participate on the panel today. Next slide. So before we get started, I will share a brief genesis of how Kept Health came to be. And it was essentially two pathways in my personal life that came together. First and foremost, I am a dermatology patient. And unfortunately, I went through a 2.5-year journey several years ago to find the care that I needed. And unfortunately, had a very difficult time finding a dermatologist, as well as other health professionals that could uncover the root cause or what was going on internally with my health that was then causing my chronic skin conditions. And unfortunately, I also had a difficult time finding experts who knew how to diagnose, treat, and care for skin of color. And also during this time, I was working with one of the largest retail healthcare companies, and our innovations team had a front row seat to see how technology was shaping the future of healthcare, and then also how healthcare policy was then impacting the future of healthcare as well. Next slide, please. And so what we're doing at Kept Health is reimagining dermatology and skin health, bringing awareness to the fact that dermatology is simply not cosmetic. It is a medical science. So we serve a number of women on our platform, yes, who do come to us for cosmetic reasons, but we do serve a large patient population who have thyroid disease, health diseases, such as cancer, heart disease, and other internal conditions. And so our goal is to make skin health personal and accessible care actionable for all women with a whole person care approach. So what does that look like? For example, real quickly, at our core, we have an inclusive AI system that is also integrative. So that means we are striving to be the industry's first AI system with equal representation of skin of color. And we enhance that with different metadata. So that's health history all the way to behavioral health hazards. And then we use that to power our telemedicine platform. So we can decrease misdiagnosis and undiagnosis, yes, with skin conditions, but also with internal health concerns. And on this journey, I had an opportunity to meet hundreds of very powerful entrepreneurs. And next slide, please. None of us entered into this entrepreneurship journey with our eyes closed or with a naive spirit. However, our everyday current reality is bleak. Again, if we look at the numbers, around 2% of female founders get funding, and less than 1% will be allocated towards founders who are like myself, Black female founders. Next slide, please. However, my goal today is to share the stories and the women behind the numbers through two experiences. First, when seeking traditional VC capital, and also with seeking R&D funding. Next slide, please. Not too long ago, there was a project called the Diane Project that looks at the current state of women entrepreneurs. And in that report, there were 3 fundamental factors that jumped out to me that I want to share with everyone today. That goes against the contrary belief of what we believe women entrepreneurs are coming to this experience with, and the skills that we have and what we're looking for. So the first is, there is the reality that we all need to face, is that women entrepreneurs, we do need to have the understanding that we do bring the fundamental skills and experience to lead high growth ventures, especially when it comes to healthcare. Not simply because of a lived experience, but because the majority of us actually do have a healthcare background. Here's one experience that I was able to gather for our conversation today from a founder. She says that her 15-year career experience was questioned and downplayed consistently with investors. Also, when she was in accelerator programs, she was consistently matched to mentors with less professional experience and track records. So that hindered her growth because she did not have the quality advice that she needed to quickly advance her company. And this leads me to the next point. Over mentorship harms entrepreneurs, especially women entrepreneurs. We need less mentorship and more capital. Here's another quick example. I quickly learned that pitch decks don't secure funding. 1,000 mentors don't open doors. I had to find advocates that my male counterparts have, who set up deal meetings for pilot deals, for example, not polite introductions. These programs overemphasize pitch practice, decks, pitch competitions, and don't set up real access for capital. Lastly, pattern matching, which I'm sure all of us on this call are familiar with, but it still remains a hindrance. Here's 2 powerful examples. First, a potential advisor suggested I hire a white male to pitch my company, or hire a founding team member who was more relatable. This causes a problem. Going forward, advisors, investors, and partners will look at her male employee as their leadership figure in her own company. Lastly, another personal example. I was told that although I went to a high-ranking graduate school, I would likely not receive any funding, as I'm a Black woman who went to a HBCU for my undergraduate degree trying to start a health tech company. These stories are startling and unsettling. However, they do not hinder women entrepreneurs. Next slide, please. Also, there's another experience that we face when seeking public and private R&D funding. When it comes to funding for health disparities, unfortunately, grant reviewers may question the significance of focusing research on minority populations. Also, when we look at the competition for funds, there is a concerning growing trend of already successfully funded non-minority researchers who secure funding for the increasing health disparity focused funding opportunities. One last example. We recognize the gaps. However, we don't find the technology innovative enough. We also can't determine if this is a need for the population you serve, as it relates to the overall majority population? Also, is this even commercially feasible? Also, most clinicians receive adequate training when we know this is not true. As of today, unfortunately, most medical schools do not provide a core curriculum around understanding how health issues impact women or how to properly care for minority patients. Next slide, please. Looking forward, there are two areas that female founders are looking for more assistance on. One is the allocation of R&D dollars that are spread across genders and minorities fairly, and also looking at grant acceptance not being heavily tilted towards already being funding dollars. Also, we would like to see the creation of founder-friendly investment programs over mentor educational programs, providing pre-seed and seed stage capital, as healthcare innovations require a larger development period and runway of time. As a conclusion, I would just like to say that we all have a role to play in making sure we are investing in women entrepreneurs. Investing in women entrepreneurs is good business, both financially and by creating long-lasting impact. Finance, however, cannot single-handedly change social norms, legal rights, and unconscious bias. It can, however, act as a catalyst to adjust the gender and racial imbalance and help close the financial gaps. By investing in women entrepreneurs of all backgrounds, investors are providing a more prosperous future for decades to come. Thank you.
Thank you so much, Sheena. I really appreciate that presentation. Next, I'd like to introduce Valerie Palmieri, who's been a steadfast advocate for women's health disparities. She was recently appointed executive chairwoman of the board of Aspiro's Women's Health after previously serving as CEO and COO. Valerie?
Thank you, Amy. And thank you to Congress for taking the time to listen to these short overviews on the gaps in women's health. I also want to thank Congresswoman Frankel for opening remarks, and also Women's Health Innovation Coalition and G2G for organizing this platform to bring awareness to the large gaps in women's health. Next slide. Could you please play the video? Thank you.
Every woman is different. Our makeups are different.
As physicians taking care of women, we have to acknowledge the disparity that exists in ovarian cancer.
40 years ago, CA-125 was created for those who had access to care, primarily Caucasian women.
We have a desperate need for a better test for African-American women for early cancer detection, for monitoring, because the current test, the CA-125, is not an adequate test.
We go into our doctor's offices, we go to these different places to receive care, and then we're just given outdated information. It's important to know that Over1+ exists and that it's available.
Over1+ offers testing using a multi-biomarker algorithm, which measures changes in nutrition and inflammation. And that is the very unique aspect of Over1+. It is resolving a disparity in testing that exists for African-American women.
We're in the United States of America, and we are still fighting to have a place in our healthcare, and it should not be that. It's important to know that Over1+ exists and that it's available.
Thank you, Amy. Next slide. Apologize for having some technical difficulties. Next slide. Okay, so the reality, there's two large women's health diseases that have been unacceptable and need the research and funding. Number one is ovarian cancer. Number two is endometriosis. Ovarian cancer is the only gender-specific cancer with greater than a 50% mortality rate. And just to give a comparison to breast cancer, so 1 in 10 women die from breast cancer, while 1 in 2 women with ovarian cancer. For Black women, ovarian cancer has a much higher mortality rate. It's 62%, while for white women, it's 54%. Both very high, but higher for Black women because of access to care issues, coupled with technology that is used today. And regarding research, today ovarian cancer receives 56% less NIH funding than prostate cancer. While prostate cancer survival rate is 98%, ovarian cancer is only 46%. And in terms of endometriosis, very large disease, affects 11% of all women in the US, takes about 7 to 9 years to diagnose, and we're spending tons of dollars, $26 billion if you look at healthcare only. If you include economic burden, it's about $69 billion a year. So in aggregate between ovarian cancer and endometriosis, we're spending about $74 billion a year. Next slide. So our mission is to transform women's health for all women, regardless of age, race, ethnicity, and economic status. And we're starting with ovarian cancer. Next slide. The root cause of the gaps in ovarian cancer really come down to inadequate tools. The doctors have 3 tools available today, which really are insufficient. Number 1 is clinical assessment, which is physical exam and ultrasound. Number 2 is blood tumor markers. Some of that actually been around since 1978. And when you're measuring a tumor marker, it's too late. And number 3 is tissue analysis. A lot of cancer is assessed with a biopsy, but with ovarian cancer, in the case of benign disease like endometriosis, it's basically you cannot biopsy your pelvic cavity. So you require actually surgery for diagnosis and treatment. Next slide. So here at Aspire Women's Health, we are actually solving this with a multimodal approach. And our initial product, which is OVA1, actually spawned out of congressionally directed research out of the DoD with the work of Johns Hopkins and Aspira. So this product that we have in the market today, it's FDA cleared and in ACOG guidelines, has actually come out of this core research. We are also taking it further and working with large academic centers such as Baylor, as well as Dana-Farber, Brigham and Women, as well as the University of Lutz. So we are constantly expanding this mark with ovarian cancer. Next slide. So the current product on the market, as I mentioned, that is an ACOG guidelines and FDA cleared, actually has a very strong sensitivity at early stage. And what you'll see here is that OVA1 Plus with clinical assessment, which is ultrasound, is 98%, while CA125, which is the marker that was created in 1978, is actually 69%. So same blood test, which one would a woman want to have in terms of finding the cancer at early stage when she can be cured? Next slide. And here we are in terms of looking at the differences in race and ethnic disparity. And we actually started this in the Philippines, looking at the Pacific Asian population. The next group of women that we actually evaluated was the Black population. And you can see here the CA125 on the left and CA125 and HE4, both of them perform in a subpar way versus OVA1. And we believe this is primarily due to the fact that OVA1 is measuring changes in nutrition, changes in inflammation, which actually have no racial barriers. Next slide. And when you look at improvement in health, you have to consider also how does it make a difference in terms of health economics. And here actually, by making a difference in the health, we're saving tons of ovarian cancer healthcare spend in addition to endometriosis spend. And it really comes down to detecting the risk of ovarian cancer at an early stage. So you can see the difference here of the cost of early stage detection versus late stage detection. This is a study with 93,000 women. The costs are very large. And right now today, we're spending $5.2 billion with 1 out of 2 women dying with ovarian cancer. And right now we're spending up to $69 billion, including economic burden for endometriosis. So in aggregate, these 2 diseases are very costly with very poor outcomes. Next slide. The key with having great technology, most of all, is getting access and equal access. So here we are in our call to action. We are looking at access for all as essential. Here's a map of the US where you see that right now today, the ovarian risk technology, which we support, is only covered by Novitas, which is one of the Medicare administrative carriers. So we are really looking to ensure we have access for all. The average age of ovarian cancer onset is 63. The average age of death is 70. So this is very important to the Medicare population. Next slide. And it's always important to understand it from a patient perspective. Why is it important and what are patients seeing and hearing? And these are three of our patient advocates that experienced the use of this older technology first off, or tried to get access to our technology. And what you'll see here is a common theme. They had delay in access. They had limited access to the best-in-class technology. So it's a common theme. In fact, there's a new word that's out there. There's been some recent articles, is medical gaslighting when it comes to listening to women, especially listening to women of color. Next slide. So here's our call to action. Number one is the most common test, CA-125, which has been on the market since 1978, may miss anywhere from 38 to 46% of ovarian cancers in Black women. We want to fund large non-Caucasian population trials to change the standard of care. Number two, 65% of ovarian cancer is detected at stage 3 and stage 4, where anywhere from 70 to 90% of women die. We want to ensure that as a result of this, we get all women detected with ovarian cancer at early stage. So we need to improve the access to the latest technology for all. And number three is 11% of all women are impacted by endometriosis. They have a loss of quality of life, fertility impact, maybe a loss of living well. We need to allow breakthrough designation to include 4 years of provisional coverage for reimbursement coverage. In aggregate, so in summary, we're spending right now today about $73 billion, $74 billion on these two diseases, both ovarian cancer and endometriosis. We need national Medicare and Medicaid coverage to ensure all women get access. We need to reduce costs, but most importantly, improve the quality of life and well-being of the women in the US. This Congress has the chance to be the change that women have been waiting for. And it's so critically needed as we approach women's health that we fund these trials for non-Caucasian women. In addition to that, we ensure that all women have access to the latest technology. Next slide. And thank you for listening.
Wonderful. Thank you, Valerie. That term medical gaslighting it speaks to me. I think we've all experienced that at some points in our history with physicians. The next, just a reminder, if you have questions, make sure to drop them in the chat. We're looking forward to getting to those at the end. Next, we have Natalie Buford-Young, who joined Springboard Enterprises as CEO in January 2021. She leads Springboard's mission to accelerate the growth of entrepreneurial companies led by women through access to essential resources and a global community of experts. Natalie.
Thank you so much. Hi, I'm Natalie Buford-Young, the CEO of Springboard Enterprises, and thank you for the opportunity to join you today. And Springboard is a 22-year-old not-for-profit 501c3 and focused on accelerating the growth of women-led companies in technology and life sciences by providing access to essential resources and a global community of experts. And it's our powerful community of entrepreneurs, investors, and advisors that are the key drivers behind our impact in accelerating the success of accomplished entrepreneurial women leading technology and life sciences companies. Our results speak for themselves. In our 22 years of operation, more than 850 women have come through our program. 26 have gone public. They've had more than 225 significant M&A transactions, and their companies have built more than $36 billion in value. Next slide. With Springboard's track record of success and the realization that many of the women entrepreneurs in our community are innovating in the women's health industry, in May of 2020, we launched the Women's Health Innovation Coalition to serve as a collective voice to drive women's health innovation and investment. The Women's Health Innovation Coalition is composed of innovators, investors, clinicians, analysts, and executives with the shared goal of advancing innovation in women's health. By forming the Women's Health Innovation Coalition, we're amplifying the work and research of all of its members. Rather than recreating the wheel, the coalition facilitates connection and awareness of the work that's already being conducted. And while we all on this call most likely fundamentally understand that women are biologically different than men, when it comes to investing in women's health, only 4% of research and development is dedicated to women's health issues, even though women today make up almost 50% of the total population, and the economic burden for women's diseases is currently more than 500 billion. Next slide. It's important to understand that women's health is not just about menstruation, menopause, maternity, and breast health. Researchers have found sex differences in every tissue and organ system in the human body. Still, medical science has a preference where, for conditions that affect all humans, men are more commonly studied. Traditionally, women's bodies have been seen as far too complex due to hormone fluctuations and thus often excluded from clinical trials. Next slide. With that in mind, the Women's Health Innovation Coalition is initially focusing on sourcing innovative solutions to address unmet needs in 7 key diseases, conditions, and indications that either solely, predominantly, or differently impact the health of women. The 7 are autoimmune, oncology, aging and bone health, gynecological and sexual health, reproductive health, cardiovascular health, and cognitive and brain health. And you can see in this chart the 7 areas in the center, and then there are subcategories as you move out towards the edge. Next slide. You've heard many stats today and will likely hear more. Here are a few that we find staggering and motivate us to keep working together for solutions. Almost 2/3 of Americans with Alzheimer's are women. Of the more than 6 million people aged 65 and older with Alzheimer's in the United States, nearly 4 million are women. And a woman's estimated lifetime risk of developing Alzheimer's at age 65 is 1 in 5. Endometriosis affects an estimated 1 in 10 women during their reproductive years, which is usually between 15 and 49. That's approximately 176 million women. And non-smoking women are 3 times more likely to get lung cancer. And the lifetime risk of stroke for women between the ages of 55 and 75 in the United States is 1 in 5. Stroke kills twice as many women as breast cancer does, making stroke the 3rd leading cause of death for women. And stroke is the leading cause of death among African American women, and they're more likely to die from a stroke than non-Hispanic white women or Hispanic women in the United States. And lastly, of the 23.5 million Americans suffering from autoimmune disease, 80% are women. Next slide. There is tremendous room for improvement in women's health outcomes, and it will require dramatically improved levels of research and funding for companies innovating in women's health. As Springboard is an organization supporting women entrepreneurs, and we created the Women's Health Innovation Coalition to focus on matters related to women's health, we have a unique perspective on the challenges women face with investors and within the industry. Investors like Steel Sky are committed to making a difference in women's health. We need more to follow suit. Next slide. Until then, here's the reality. In 2019, women founders received a paltry 2.8% of venture capital funding. In 2020, it dipped even lower to 2.3%, and then again in 2021 to 2%, the lowest since 2016. And it's less than 0.5% for women of color. By comparison, all male founder teams raised about 79% of total venture capital funding. In talking with many of our women entrepreneurs, there are some consistent themes in why this decline and disparity exists. Regarding the decline, during the pandemic, investors faced with market uncertainty reverted back to their more comfortable networks and were less willing to take a risk on unknown entities, including women founders. Next slide. The bigger question is, why are women founders receiving such a low percentage in the first place? And the answer is, like attracts like, and investors are no different. Investors tend to invest in either people that are like them or solutions they understand. The investor community is still predominantly male, which creates the bias towards investing in male founders, or general population solutions. Women only make up 5.7% of venture partners. And similarly, a Kauffman Foundation study of female entrepreneur funding found that VC firms with women partners were 2 times as likely to invest in startups founded by women and over 3 times more likely to invest in startups with women CEOs. And since investors invest in what they know and understand, the male-dominated venture capital industry perceives women's health as too niche. And I've heard of instances where investors remark that they need to talk to their wife or their girlfriend to validate whether an innovative women's health solution is needed or wanted. And others are quick to look around the room and find a woman investor that they can refer you to. Forbes interviewed a woman entrepreneur recently who said the investor wouldn't fund her because he essentially found women's health boring. And what I'm hoping he meant was that he didn't have a great enough understanding to evaluate the opportunity. Next slide. But there is good news. Despite all of these challenges, studies show that women founders and women's health present a great market opportunity. Emerging research projects that the global market for women's health will reach $60 billion in 2027 compared to its $18.8 billion valuation in 2019. Women and minority health innovations are profitable, resilient, address huge gaps in healthcare, and improve patient outcomes. An analysis by the Boston Consulting Group found that when women-led startups do get funded, they deliver higher revenue, more than twice as much per dollar invested. That's 78 cents on the dollar versus 31 cents. And The Economist found that women's health tech is a huge market because it focuses on solutions that aid most of the world's 4 billion women at some point in their lives, whereas male-aimed health tech often focuses on conditions that affect a small percent of the male population, such as erectile dysfunction, which is 10 to 20% of the male population. Research has also shown that when inventors set out to solve a health problem, male inventors are more likely to solve for a male-oriented solution, while women-led teams solve for both sexes. Not only do healthcare innovators, like the ones we work with at Springboard and the Women's Health Innovation Coalition, help to improve patient outcomes, but they can also be extremely lucrative. Research to Guidance found that there are more than 3,000 app-based products focused exclusively on the health of women, and the report predicts that market revenue for the industry will reach $297 million by 2024. According to Melissa Bradley, according to Melissa Bradley, founder of 1863 Ventures, an accelerator, when surrounded by the community and resources, go to the last slide, please, businesses owned by women of color are resilient. The accelerator found them to have 97.5% survival rate during the first 6 months of the pandemic, and half of those companies created 2,000 or more new jobs. For comparison, in 2019, the failure rate for startups was around 90%. Lastly, Latina entrepreneurs represent nearly half of all Latino businesses, which account for almost 2 million of small businesses in the US. According to data from the Latina Community Foundation, they also create businesses at a rate 6 times faster than other groups in the US. Next slide. I'm confident that the information shared today by all of our speakers will further your understanding of women's health and women entrepreneurs, and that they are worthy of investment. We request that Congress address these gaps and ensure women and minorities receive the funding that they need. On behalf of Springboard and our Women's Health Innovation Coalition, thank you for the opportunity to present to you today.
Thank you so much, Natalie. Appreciate that presentation. I am pleased to introduce our final panelist, Linda Grube. Over 30 years, she has invested in public and private life science companies. She also co-founded Avestria Ventures, which invests in early stage women's health and female-led science ventures. I'm going to turn it over to you, Linda.
Thanks so much. And I want to thank Congress for your time today. And I want to thank G2G Consulting and the Women's Health Innovation Coalition for putting this great panel together. I'm going to wind up telling you a little bit about why we started Avestria Ventures, and you'll see some of the same statistics presented that you've already seen. So you'll see, in other words, these statistics were compelling enough for us to change our careers and focus on this amazing opportunity. First slide, please. So as we've been talking about, when you look at the history and current status of women's health, clinical research and medical education has been based on men. And yet significant biological differences exist between men and women in many diseases. And we've talked about this: cardiovascular disease, Alzheimer's, autoimmune disease, oncology. And it wasn't until 1993 that the FDA no longer banned women of childbearing potential from participating in clinical trials. So as many of my colleagues have mentioned, the research was not based on women. And in 2015, and this is the year we have the most current data for, only 28% of the studies actually analyzed the clinical data by biological sex. So whereas they may have included women in their trials, they didn't bother to analyze the results by the biological sex. And it wasn't until 2016 that the NIH finally required safety studies to include female animal cells and tissues. Between 1997 and 2001, 8 out of 10 prescription drugs were pulled from the market due to safety issues in women. And again, this is because women were not included in the clinical trials. Other drugs, like Epital for epilepsy, affect minority patients differently. And this has to do with genetic differences or certain mutations. One piece of data that's come out is that if we were to eliminate race-based health disparities, we could save the system $135 billion per year. So this is not an insignificant problem, and solving for it could have substantial economic differences. Next slide. So we've gone through the fact that there are biological differences between men and women, but we're seeing again that these are not reflected in current funding. And as a number of people have mentioned, only 4% of all public and private R&D funding goes to women's health products and services. And when we look specifically at the NIH, we see that while 66% of Americans with Alzheimer's are women, only 12% of NIH funding for Alzheimer's and related dementias is focused on women. Similarly, women are estimated to account for 58% of all rheumatoid arthritis cases, and yet only 7% of NIH funding is focused on women. Finally, while women are 50% more likely to die in the year following a heart attack than men, only 4.5% of NIH funding for cardiovascular disease, heart health, is focused on women. Next slide. So while we might think that if the NIH funding isn't perhaps moving to parity, we might hope that the private investment community is. And sadly, not only is it not, but it's trailing behind the trends in NIH funding. And we moved into this area, again, because we thought it was an overlooked investment opportunity. Right now, only 1% of all US VC investment in the life sciences went to women's health companies in 2020. And yet 80% of all women's health startup founders are females. So you're not going to solve the women's health issue if you don't also solve the investing in female entrepreneur issue. As people have already mentioned today, diverse founding teams with one or more racial or ethnic and gender minorities, their businesses outperform. They wind up with a 30% higher multiple on invested capital upon exit versus homogeneous teams. They wind up with a 63% higher valuation when there's one or more female founders versus all male founders. And they have a 65% higher valuation with one or more ethnically diverse C-suite members versus all white C-suites. And what we've mentioned this before too, venture capitalists tend to back like entrepreneurs. So firms with at least one female partner are 2 times more likely to fund female founders and 3 times more likely to fund companies with female CEOs versus firms with all male partners. And yet today, and each of us seems to have slightly different statistics, but they're all in the same ballpark. Only 4% of all VCs are female, and only 4% are Black, and only 2% are Latino or Latina. So you can see why we're winding up, if we've got different investors, we're going to wind up investing in different areas and different types of founders. Next slide. And we're also seeing that this gap in access to capital is stifling innovation. And if we're going to make improvements to women and minorities' health, we're going to have to require changes to the investment community. Today, white males manage 99% of all US financial assets. They manage 93% of US VC dollars specifically. In 2021, 87% of all VC funding went to all male teams. As far as the VC partners, 84% are male, 78% are white, and 65% of VC firms do not have any female partners. The other issue we're running into is that 90% of all women-led VC funds are considered emerging managers. That means that they've only been formed relatively recently, and they lack the long-term track record and asset size, which is required by institutional investors. That means there's sort of a chicken and egg issue where while women and minorities are starting their own VC funds, they are not getting the backing, because they haven't been around for 10 years and they aren't managing 300 to 500 million plus in investment dollars. Next slide. So what are some of the things we can do about it? I think the easy one for Congress may be to encourage the NIH to provide equitable funding for women and minority health research. As we can see today, there are really, really significant gaps. Another thing Congress could do was they could pass legislation that requires institutions that receive federal funding to invest a certain percent of their endowment assets, both with diverse fund managers, with diverse founders, and in women and minority health companies. So obviously the institutions we're talking about there are largely academic institutions. The third thing that people in Congress could do is, I know that you all invest with the thrift savings plan. You should be asking them to include information about who those individual portfolio managers of the FSC and I funds are. And you should request that 50% of those managers be female and 40% of those managers should be minorities at least. And that would just provide a more equitable representation. And thank you for your time today. And we have an optimistic view about the future.
Wonderful. Thank you so much, Linda. Next slide. So, I think we've heard from our expert panelists who have provided their recommendations. What can Congress do about this? We would not be a very good government affairs firm if we didn't have our own recommendations, which we do for Congress. The first is create a pilot program through an appropriations request for the Small Business Administration to give grants to women and minority health innovators. They need that capital. We can be a conduit for making that happen. Number two is increase federal funding streams for research, particularly conditions that disproportionately affect and present differently in women and minorities. Third, put in place an immediate provisional reimbursement for new FDA-approved innovations in women's health. Those are our recommendations. We thank you for taking the time. We're going to open it up for questions right now, and I'm actually going to take a moderator's privilege and start the questions on my end. Valerie, I believe it was you mentioned a term that I hadn't heard before, but it really struck home. Medical gaslighting. It's something that I've experienced personally. Can you talk about diagnostics, investments in diagnostics, why it's so critical to improving patient outcomes, especially when there seems to be a pattern of not, missing the signs or not listening to women patients?
Thank you, Amy, and thank you for noting that. There's a recent article in Forbes, and it's actually was on CNN this week. Medical gaslighting happens when either the individual is trying to explain their condition are basically diminished or not listened to, or trying to really understand the root cause of how they're feeling versus just taking care of the symptoms. And especially in diagnostics, where 70 to 80% of decisions we make are from a simple blood test or a urine test or a body fluid test. So it's very important that the doctor gets objective data to make decisions, as well as the individual understands how to communicate their symptomology. And I think the best thing that I can give in terms of lessons learned and seeing this journey for ovarian cancer and endometriosis patients is be your own advocate, never back down. You know you're normal. And until you get the answer and understand root cause, you need to ensure that you get the solution. And diagnostics can play a very large role in a non-invasive way. Thank you, Amy, for the question.
Wonderful, thank you. I'm going to ask a question from the audience. This is probably for either Linda or Natalie. Lots of people understand the problem when it comes to successful funding. VCs ask the tricky questions around reimbursement and sustainable business models. What are some of the successful business models that can be implemented early on to gain market traction?
I'll start answering on that one. So there are some types of healthcare businesses that won't have early market traction, if by what you mean are commercial sales. I mean, obviously, so many healthcare companies require many years of R&D before they can produce a therapeutic or a diagnostic. So I guess there are different ways to discuss what market traction is. But around your first question, what we ask our earliest stage companies to do is we want to know that they've thought through all of the steps, right? Have they identified a company to help them with reimbursement, right? Have they thought about how they're going to get through the FDA? Do they have a consultant in place to get through the FDA? Do they know the answer to, are there existing codes in place? Are there codes that could be used in the interim while they go to put in unique codes? So, we don't expect anyone to be there in the very beginning, but we want them to have thought through it all, and certainly to have identified some of the people that can help them get there over the years. I don't know if that helped or not.
Yes, wonderful. Thank you. Linda, just continuing on with that, in the investment world, ROI is king. It's a top priority. If there's so much money to be made in this market, I think it's estimated to be 1.18 trillion by 2027, then why are we still seeing just a dearth of investment in women's health innovations? Do we all have to just become venture capitalists and start funding this on our own? What does the future of investing look like?
Well, to be honest, the only answer I could come up with was to become a venture capitalist myself. So that is, in fact, I think a key issue. And I think many women who have the backgrounds to become venture capitalists are doing it. And it would be great if we could ask our male venture capital colleagues to focus more time and energy on it. They may, my guess would be that's not going to happen until they see more profitable exits. And we're starting to see those now. One of the problems has been some of the large strategics who are potential acquirers have actually shut down their women's health businesses in relatively recent years. But then again, we're seeing others that are building them up. And when we see the large corporates build up their practices, that provides potential exits for the innovators, and that will lead venture capitalists to spend more time on this space. But they won't get there until they see the financial returns, and they'll be made by someone else first. So yeah, what I can tell you though is we do have, it's hard to invest in venture capital. So one of the things you can potentially do if you're not a person with a large amount of disposable income is you can talk to, if you went to college, you can talk to your alumni offices and ask them to report what percentage of their endowment dollars are going to women managers and what percentage are going to women entrepreneurs. That's one thing you can do. Another thing you can do is there are venture capital firms, such as our own, that do accept funding by high net worth individuals. Unfortunately, it is often high net worth individuals. There's a group called Portfolio, which accepts much smaller investments, which many of you may want to seek out, and they've got a great femtech fund.
Wonderful. Did somebody else want to
I was
comment?
just I echo a lot of what Linda said. I mean, yes, we'd love to have more women investors in the investor community, and that will impact us. It's going to take a while to get there. And also, what I'm seeing is a lot of the funds are smaller size funds. So short of that, or before, until we get there, part of it is really going to be building compelling business cases, having strong outcomes, really communicating with investors what the opportunity is. And it's not just the entrepreneur standing in front of them pitching for money, but it's the rest of us applying some pressure or focus and education to help them see the addressable market.
That's a really great answer and a great segue into this question from an attendee for Natalie. What are some of the ways that Springboard promotes more women entrepreneurs and founders?
Oh, 22 years of it. So I'll try to be concise. A lot of it is by the community, building a strong community of investors and advisors. And to what Sheena talked about earlier in her talk is it's not about mentorship. People can be over mentored. It's really about having actionable connections that you can provide to help propel women entrepreneurs forward. So when we look at women entrepreneurs, we're really identifying where are they in their stage of growth? What do they need immediately? What are they, what are their milestones? What are they creating as far as their path to commercialization? And then we start plugging in really relevant connections. That's the power of community. So that's one way. And then of course, building stronger investor relationships, giving them greater access, making it easier for them to take time to look at women entrepreneurs and women's health. So it's a lot of good communication and a lot of great connections.
Wonderful. Thank you. Appreciate that answer. I don't know, I think we have time for maybe one more question. I am going to go ahead and ask it and take prerogatives, moderator's prerogative again. Last question here. I think it's 2022. We have all of these, sources of data and information that we have at our fingertips. Why is there, just a lack of awareness on, some of the gaps that you've addressed today, like ovarian cancer, heart disease, Alzheimer's, and just so many others. What can be done to, to get at this, especially when the majority of these diseases, such as Alzheimer's and dementia, overwhelmingly impact women? I think that would be for anyone.
I can start on that. Hang on, turn my camera back on. It's about telling the story. It's about getting the messaging out there. I was on a webcast the other day and I talked about the 2% of venture capital funding going to women entrepreneurs, and the host said, why doesn't anyone tell us these things? So here we are, telling people these things, that 4% of research and development goes towards women's health matters, may be news to people on today's call. It's, we live it all the time, but I think we have to remember to keep telling the story because the statistics that we talked about today are shocking.
Wonderful. Sheena, do you have any thoughts?
Yeah, definitely want to follow up to what Deborah said. It's finding ways to communicate, taking advantage of all the social media, new media tools that we have. That's going to spread the word, not just for investors or other types of individuals who want to support founders like myself, but it also increases the education of women patients themselves, right? So now they're more powerful to become advocates. And then it's moving into speaking with your clinicians, and then clinicians taking that and just moving it up the chain. And so it's a community conversation, right? It's not siloed with investors, entrepreneurs, and the patients just living their daily experience, not knowing like there's a reason why they feel the way that they do. There's a term such as gaslighting. So I think it's just creating the communication, the channels, and just being innovative in the way that we do that.
Wonderful. Thank you so much. It's such a great note to end on. We will continue to communicate with the Women's Health Innovation Coalition. I want to thank everyone for attending today, to the panelists for participating today and sharing your knowledge with us. We really appreciate the discussion. We'll be sending slides out to participants, and we just really thank you for being a part of such an important discussion.